Thank you so much for joining, everyone. My name is Madeline Miller, and I'm our Director of Development. And I think we have to start off by just saying Happy Rare Disease Day today. I'm wearing my zebras to celebrate all of our rare disease patients, warriors that we have met throughout our time at the foundation. So very excited for it to be Rare Disease Day and promoting awareness, but very excited for this Ask the Experts webinar, because throughout the month of February, our foundation has recognized a month of awareness for our multifocal motor neuropathy community. And we're concluding this awareness month by having this fantastic special Ask the Experts session focused on the care and treatment of MMN. We're joined today by Dr. Gareth Perry, who serves as an emeritus professor at the University of Minnesota and is a clinical senior lecturer at Otago University in New Zealand. And we're also joined by a great friend of the foundation, Mr. Clive Phillips. He's an MMN patient, a cyclist extraordinaire who started the Making the Most of the Now campaign to raise awareness and, most importantly, much needed funds for MMN research. So we have some questions for these two experts, but please feel free to type your questions into the Q&A box towards the bottom of your screen. We will try to respond to as many questions as possible. If we don't get to yours, please email it to us at info@gbs-CIDP.org after the webinar, and we'll get an answer for you. So thank you very much for joining us. And let's start by doing a quick overview of the diagnosis process for MMN, focusing on the symptoms that are presented, the tests are done, and then what experience is like for a patient. Dr. Perry, we'll start with you. What symptoms would lead you to suspect an MMN in a person, and what tests would you order to diagnose MMN?
I think the greatest barrier, if I may start by saying the greatest barrier to the diagnosis of multifocal motor neuropathy is not thinking of it. And I think that was a huge problem in the past, getting to be less of a problem now. It's a motor disorder. That is, it causes weakness. That's the main symptom of this disease. Patients can also get some cramps and muscle twitching, but overridingly, it is weakness. They may notice muscle atrophy, that is shrinkage of the muscle. And I've had patients who notice that and say, oh, what's that? And hadn't noticed weakness. But again, weakness is the main thing. And the second is it's multifocal. What does that mean? It means it's like a patchy disease, one nerve here, another nerve there. And it predominantly involves the upper limbs, the hands and arms, and legs definitely involved, but less frequently. And so somebody who has weakness that is progressive, that mainly affects the hands and is different in different parts, or maybe more on the left than the right, or it may involve one nerve in a limb more than another. This is the patient who should think of this possibility. I should add that early on, but less these days, fortunately, many of these patients were diagnosed as ALS, or what we call in New Zealand motor neuron disease. And it's critically important to make that distinction, because motor neuron disease, or ALS, is invariably fatal disease, whereas MMN is not, and even more importantly, MMN is treatment. So that's what I look for, makes me suspect MMN.
And just a quick question, what tests would you order then to diagnose?
Well, the test is based entirely on the nerve conduction studies, okay. Those lovely tests where we give you the electric shocks and record the responses. And we say it's nothing, but we're not having it done to us. It is a bit uncomfortable. Clive is smiling there. But at least at the moment, there is no other way of making this diagnosis. There are other tests we do. We look for certain antibodies in the blood that are present in 50 to 60% of patients. Their absence doesn't exclude the diagnosis, but their presence helps to confirm it. Those same antibodies can occur in other diseases, but at much lower levels. And so the key factor in MMN is that these levels are very high. So one blood test, one electrophysiological study with the nerve shocks, and a high clinical suspicion, and that's about it.
Clive, I will go to you as a patient. Is this very similar to what you experienced, or is there anything you can add on here about your journey to get diagnosed?
It certainly is very similar. I think that the challenge always is actually getting to the point where you think you've got a problem that's worthy of investigation beyond, as was the case with me, my doctor thinking, oh, you just need, you're just losing a bit of strength. Let's face it. I hate to want to say it, you're becoming middle-aged. You need to do, you need to get a ball or rubber bands and strengthen your fingers. And I think I had probably, over the period of about 5 years, mentioned it to my doctor, mentioned a loss of hand strength to my doctor, probably 3 or 4 times. I was going overseas a lot and I was going for medicals quite a bit. So I'd relatively regularly see the doctor, and nothing raised his suspicion, or mine actually, until, and I've said this, given this story to many people, until I couldn't do a thumbs up. And then I thought, okay, that's not normal. That's not just a strength. There's something not working here that for, years and years, that's just automatically happened. At that point, I was given an MRI. They were looking for whether the hand was a kind of problem with, nerve being pinched in the spine or something like that. That was ruled out pretty quickly. At the point at which I got to see a neurologist, I felt like I was on an accelerated track for diagnosis, had a nerve conduction study, followed up very rapidly with being prodded and poked by about kind of 12 neurologists within a week, because by this stage I was presenting, and latterly my neurologist said he'd never seen anyone as weak from the condition. And then I did have the spinal tap. I think probably the spinal tap was the least pleasant of the experiences. Not at the actual time, you're just lying there hoping that you don't move and the needle goes to the wrong place. But the 2 or 3 or 2 days after it were pretty uncomfortable, quite a bit of pain. But that came back negative on the GM1 antibodies that they're looking for, or sometimes looking for. But so it was my diagnosis was all about that nerve conduction study and the presence of conduction block. So I was a pretty classic case, but I think I was an easy diagnosis because the condition had advanced to the point where my strengths, when they measure the kind of hand strength, they're using a 1 to 5 scale. I don't know the name of it, but I was coming up with 2s when normal is 5. So it was, I think it was an easy case, but that's only because between me and my doctor, I suppose, we left it long enough that it had progressed.
And we actually
but that's a very common story. People, first of all, primary care physicians or GPs are just not aware of this. This is a rare disease, and so I don't necessarily blame the doctor for delay in diagnosis. And even neurologists don't see this disease very often. And so patients do tend to take a long time to get the diagnosis. And that's a pity, because the response to treatment is better if the treatment is started early. And the MRI is really done for other reasons. That is, as in Clive's case, someone suspected possibly a pinched nerve in the neck, and so it's not done for MMN. It's done for the possibility that other things are there. And the spinal tap, the lumbar puncture, I would say is not necessary.
We've had some lively questions in the chat, and I just wanted to submit one to you guys quickly. Do you guys know in what year MMN was recognized or identified as a disorder? I feel like this could be a possible trivia question in our future.
Well, I do know. So in 1985, I presented 3 cases. I was living in San Francisco at the time, and I presented 3 cases to a meeting in Las Vegas and was showered with skepticism. People did not really believe what I was showing. And in fact, it took me 3 years to get the paper published in the peer-reviewed literature because people did not believe it. And my friend and colleague Alan Pesterunk, who was then at Johns Hopkins University, what was sort of coming at this from a different direction at about the same time. So yeah, mid-80s.
Well, let's move on to treating MMN. And Dr. Perry, what is your first go-to line of treatment for someone with MMN?
Well, unfortunately, there is only one treatment that has been proven without question to be effective, and that is immune globulin, hyperimmune globulin. This is a blood product. It is the component of the blood that contains all the antibodies that we all have to protect us against disease. And it was discovered to be effective as a treatment for autoimmune diseases as a general class. And it was tried in MMN in the 1980s and found to be effective. Unfortunately, it is not a cure. So treatment needs to continue lifelong, well, a long time, possibly lifelong. And it doesn't, because it doesn't cure the disease, despite treatment, there can be a little bit of slow progression over the decades. This is not a disease people are going to die from. They're going to have it for the rest of their lives, given our current skills in treating it or lack of skills in treating it. But this is going to be long-term treatment. Now, if I can segue to an alternative, it's not an alternative product, but it's an alternative route of administration. So over the last 10 years or so, a bit longer, people have been looking at easier ways to administer the product, because if it has to be given intravenously, you either have to go to an infusion center, or a nurse has to come to your home and put in an IV and infuse the product. And so there was some interest in whether or not the product could be given by a different route that the patient themselves could do at home. And so subcutaneous IG was introduced, and it was studied and it was compared to intravenous administration and shown to be effective. Some argument about whether it is as effective, but certainly it is effective. And partly we had to wait for the higher concentration products to become available. The initial products were 4%, and to give that subcutaneously, you would have this enormous lump under your skin because of the volume of fluid that would have to be administered. But as the higher concentration products were manufactured, then it was able to be given by that route. And that tends to be given once a week as a generalization, whereas the intravenous product tends to be given once a month, because you can give a much higher dose intravenously.
Dr. Perry, I do have just 2 follow-up questions from the audience before we hear Clive's perspective as a patient. And one is there a specific recommendation for physical therapy regime for those of us with an anti-MAG variant?
The anti-MAG, if I'm understanding the question right, is myelin-associated glycoprotein. That's a different disease. That has a clinical appearance that is quite different from MMN and does not have conduction block. It is treated differently. IVIG is either minimally effective or not effective at all. It's somewhat controversial. So it's sort of a different disease. As far as physical therapy is concerned, I'm generally extremely supportive of physical therapy. I think it makes people's lives better. And humans like to feel they're doing something for themselves. They don't want some doctor to just come in and give them something, be it a pill or an infusion or whatever. So there's that psychological benefit, but there truly is the physical benefit of learning to function within the limitations of the weakness that is present. Clive could probably speak to whether he had physical therapy because it can be very useful.
Just one more question for you, Dr. Perry. Is there a maximum dose of IVIG that a person keeps needing before it's effective? Can you talk a little bit about the dosing of IVIG for MMN patients?
Yes, so the dosing usually starts with what we call an induction dose, where a total of 2 grams of the product per kilogram of body weight is administered. And so that's quite a lot of drug, and it's usually given over a period of days. Then they transition to a maintenance therapy, which can be anything from every 2 weeks to every 6 weeks. The half-life of the product, by which we mean the time it takes for half of the product to disappear from the circulation, is about 3 weeks. And typically in medicine, we administer a drug about once every half-life. So you'd say we should give it about every 3 weeks. But there's tremendous variability, and so some patients do just fine on every 6 weeks. Others needed it a little more frequently. I've certainly had patients who metabolize the IG quickly and need treatment every week, and of course that gets to be very expensive.
Well, Clive, we'd love to hear from you about what your perspective is and when you get your infusions.
Yeah, so if we start from the beginning, I guess my initial dose, my loading dose, as it's often described, was the classic 2 grams per kilo over 2 days, and then I initially then moved on to 1 gram per kilo every 4 weeks. Now I'm on every 6 weeks. I had responded to it and still do certainly within 24 hours. My initial dose, the classic for me was I was up for the first time in about 3 years, I could give a thumbs up within 3 days of the first loading dose, which was pretty remarkable. And since then, the treatment has continued to be incredibly effective. I would say, certainly, I talked earlier about some of the measures of my hand strength and function were down at 2 out of 5. They're routinely at 4 out of 5 now. I had just started to get foot drop, so the condition has started to affect my foot, and I started to notice that classic tripping over yourself or hearing the slap of your foot as it hits the ground. That hasn't completely disappeared, but I'd say 99% has disappeared. I definitely notice my strength and my function tailing off certainly in the last couple of weeks of my 6-week cycle. But it's really a balance, and I think we all, with our neurologists, come up with a balance of how often you want to spend a day in hospital, or for others, more than 1 day, versus how much of the tailing off of your, the effectiveness you can deal with. I consider myself incredibly lucky, that the IVIG has such a positive impact, and allows me to pretty much do everything normally. You have to kind of show people where my hand is a bit wonky and my strength isn't there. They don't automatically notice it, which they were. I find, 1 day every 6 weeks is more than manageable. It's about 7 hours for me. Again, I am just lucky because I know of other people that they have to manage the dosing rate and have it at quite a low rate. And that often means they're in 2 or 3 times to get the same dose that I have. They have to spread it right out. I do experience some side effects, but they're fairly minimal as long as I prepare. And really, I think the most common side effects are tiredness, which is kind of inevitable when you think at the end of the day that your body's trying to, we're throwing loads of antibodies in and your body's trying to fight itself in some way, shape or form. So tiredness probably that starts to come on within about 2 or 3 hours of the start of my infusion. And that will take 6 to 7 hours in a day. That tiredness lasts probably a good 48 hours. I'm usually back up to normal by about 3 or 4 days after. Headaches and neck aches can be a bit of a challenge sometimes, but the trick for me is hydration before, during, and after, and that's critical. It's trying to, and this is difficult sometimes, trying not to go in stressed and tired. So I try and make a really conscious effort. I used to try and maximize the time by being online for work meetings during an infusion and trying to do work, and I realized it wasn't helping at all because my stress levels were probably going up through the roof, and that was definitely negatively impacting. And then generally I will usually take some sort of paracetamol maybe halfway through and straight after, maybe for the next day, but not too much, just to keep kind of take the edge off any headaches. I know, like I say, I'm pretty lucky. I have talked to others who find those symptoms are a bit worse. But yeah, that's.
And Clive, we just have one more question for you from our audience, and they were wondering, how long ago were you diagnosed?
Diagnosis was 3 years ago now. Yeah, and I think I've had, when I look back, I probably first had symptoms 6 or 7 years before that, but just didn't recognize them.
I remember the first time we met. I remember the thumbs up story, but I also remember you were having trouble carrying a couple beers at the bar at a time for coworkers, and that was very alarming for me. That would be my first.
Alarming for me as well, And this is the thing, right? I've always been fit and healthy. I was in the British Army. Work hard, play hard may have been a bit of the ethos, and so to find yourself where your body isn't functioning in the way you want it to, and you start to do things. My fine motor skills were just becoming atrocious. Trying to screw something together. Most people know by now, if they don't already, I love my bike and I get out biking, but trying to just little things like take the screw cap off the tire so I can pump the tire up. I was struggling to do that, and I think the hardest thing to deal with in those circumstances is just your own. It's when you start realizing those things. But yeah, the inability to go and get 3 beers at once from a bar, which is a critical life skill, has been lost to me. And I no longer, it's one of those things, because I do still have a bit less strength and less function. It's now a skill that I don't want to test, because who wants to drop a beer? But I guess I get extra steps going to and from.
That's true. Well, let's move on to our next topic, and that is subcutaneous IG. And, like you spoke about earlier, Dr. Perry, historically, IG was always given intravenously, but now subcutaneous is an option. And we'd love to invite another patient to join us and have her speak about her experience taking sub-Q. So hi, Brenda. Thank you so much for joining us today.
Hi. Can you guys see me?
No, we can see your lovely name.
No, wait, do I need to? Oh, hang on. I'm so sorry.
That's
I don't.
okay.
Oh, no, my camera should be on. I don't know why my camera's not on. It's green.
Well, we're missing your lovely face, but we still would love to hear from you.
Well, I'm
about
so
your
sad.
experience.
I have show and tell too, because I just did my infusion this morning.
Oh.
But I was going to show you some supplies.
Oh.
Yeah,
Well,
I don't know why it's not showing up.
but-
Okay. So did you want me to go over what inspired me to switch?
Yes, because I think Dr. Perry earlier gave a great description of sub-Q. Dr. Perry, do you have anything that you want to add on to that, or?
No, I have a couple of comments about Clive's experience, but I think we should go with Brenda. Brenda first, because we can come back to my comments about Clive's experience.
Perfect.
So the reason that I switched to sub-Q was because even though I responded to IVIG, I was on it for 2 years. I was very up and down, and I also was getting the really bad side effects where I'd get very bad headaches, and I would have flu-like symptoms for 3 days almost after. And I was getting IVIG every 3 weeks, and I would maybe peak a little bit and then I would drop off. And they couldn't really give me more IVIG because I was getting the side effects. So I think he was, a little worried about that. So fortunately, I was at Johns Hopkins, and my doctor was very comfortable switching me to sub-Q. So when I switched over to sub-Q, it was a little bit of a process. It took 3 tries to get the dosage right, because I think I was a little underdosed. So I ended up, my sweet spot was 35 grams a week. I started at 27, went to 30, and then 35. And in between each of those increases, I got my old IVIG treatment to kind of fill my tank back up before I started on my new dose. So for me, so for being on sub-Q, I don't have any side effects. I'm very stable. I've been stable for almost 8 years now, and with no differences. I still have my drop foot was probably the first thing that happened. So that's always going to be there, and the weakness in my legs, but everything else has just gotten so much better. And preparing for sub-Q, really, I just go get my coffee and my granola bar and my tray of supplies, head upstairs. After I do 6 needles, 3 in each thigh. That can vary depending on, like I have the fastest speed tubing, but I could probably do different needles to make it go a little faster than 3 hours. But I'm kind of in that mindset, if it's not broke, so don't fix it. It works great for me. So I go sit upstairs in my bed and snuggle with my puppies and drink my coffee. And, 2.5, 3 hours later, I'm done. And then, but I don't have any side effects. I don't need to take any preventatives. I don't need to up my water intake. I don't need to put the sub-Q in the refrigerator. It's just everything goes in a cabinet. And I can travel with it, and I travel with it all the time. So it just kind of gives, to me, it was also important. It gave me a little bit of control back, so I could kind of do it when I wanted, but it's been working wonderful for me.
It's great. And go ahead, Dr. Perry.
Just say, Mary, so Brenda's experience, sort of along with Clive's, make a couple of important points. You don't get side effects with subcutaneous, and the headaches and the sort of feeling unwell that Clive describes, and that Brenda also described when she was on IV, is not uncommon, and it's related to the rate of infusion. So there's always this trade-off. do I want to sit around for 12 hours getting a very slow infusion rate, or am I willing to tolerate a few of these adverse effects and get my dose administered more quickly? And then the alternative is do what Brenda's done, which is to transition to a subcutaneous administration. Some people like it, as Brenda seems to, other people do not. And I discuss it with my patients, and the option does exist, even in little old New Zealand. I think it is an option. I would say that I've had patients who've switched to sub-Q and gone back to intravenous. And it really just depends on the needs of individual patients. And the final point about sub-Q, there's a rare but potentially very serious complication of intravenous gamma globulin, and that is blood clots. So you can have strokes and heart attacks and blood clots to the lungs, and potentially very serious issues that are very rare, but they can occur with IV administration, never have occurred with subcutaneous. So definite advantages, some minor disadvantages, but it's principally around personal preference.
And Dr. Perry, that was a great reminder for patients to talk to their doctor about switching to subcutaneous treatment and to not make this decision in a vacuum. So thank you very much for saying that. Dr. Perry, continuing on with you, are there any other medications that you regularly prescribe for MMN patients, or are you aware of any research that is being done for new medications?
The answer is there are no other medications that I regularly use, and there are no other regulations that have been proven to be of benefit. I mean, the gold standard in evaluating treatments is what's called the double-blind placebo-controlled trial, where we take a group of patients and we give half of them the active drug and give half of them a placebo, and compare the outcomes in those two groups. So there is no other treatment that has been subjected to that rigorous testing and shown to be effective. One of the problems is that the patients that we try on other treatments are generally the patients who failed IVIG, so they're the tough ones. And so is it possible that we're missing an effective treatment because we're only treating treatment-resistant patients? We don't know the answer to that. But there are other drugs. The drug that I have tried most frequently is rituximab. It is a medication that is generally well tolerated. It's a form of chemotherapy. People have to understand that. And the studies that have been done have not shown that it's consistently of benefit. But I and many other individuals worldwide have had patients who appear to have had a very good response. I would say the response generally has been a marked reduction in the dependence on IVIG. So I've not been able to stop IVIG by using rituximab, but I've been able to go to much lower doses at less frequent intervals. The other drug that has been suggested to be effective, and anecdotal observational studies have suggested as beneficial, are powerful forms of chemotherapy. The most commonly used one is cyclophosphamide, which is an anti-cancer drug. It has a lot of side effects. But Dr. Pestronk, who I mentioned earlier, was a strong proponent of the use of cyclophosphamide. I have used it, and I have had patients who have benefited, again, in terms of being able to reduce their IVIG dose, not being able to stop IVIG treatment. People have tried interferon drugs, which are treatments for MS, but generally not being shown to be effective. There's a relatively new drug. It's been around less than 20 years, so that's new. They're called eculizumab. It is eye-wateringly expensive, and there have been occasional suggestions that eculizumab might be effective. I perhaps should segue into the fact that corticosteroid medications like prednisone that are very widely used, for example, in CIDP, related disease, not only don't work for multifocal motor neuropathy, but can make patients worse, and not just a little bit worse. They can make patients a lot worse, and so should be avoided. Plasma exchange, which is a strategy for removing the blood, then separating the cellular part of the blood from the plasma, and then giving the cells back with donor plasma, has also been tried in patients with MMN, and again, does not work and can make patients worse. So plasma exchange and corticosteroid medications should be avoided in patients with MMN. We need another treatment. We need more effective treatment. This being the 21st century, I have to mention stem cell transplants. Again, there are 1 or 2 case reports which did not show benefit. So people, I think, have the hope of stem cells as the miracle cure, but it doesn't seem to be the case for MMN. So, yeah, we need to find more treatments.
Yeah. Well, I think this is a really great segue into Clive and what you've been doing to live, continue your quality of life post-diagnosis and continuing your passions, and how you've tied your passions into raising money for MMN research. So, Clive, besides taking IVIG, what do you do to take care of yourself as you're living with MMN?
Yeah, I think I'll answer that question in a moment, Maddie. I think if I can just comment on a couple of things.
Please.
The research space, I think it's very difficult. There is a trial at the moment that I think it's argenx are running, which is the first trial of a potential new product in a long, long time, from what I can gather. But my sense is it's very difficult once you're on effective treatment through immunoglobulin. Any trial requires you to step away from that for a short period, and I think that's even when the trial's designed, as I think the argenx one is, to put you back onto IVIG or subcutaneous if you are seeing a significant deterioration. It's a real kind of mental barrier for people to get across, to step away from a treatment that's working well. So with so few of us with the condition, as a really, what I describe as ultra rare, not just rare, very hard to actually find, enough people to do the kind of double-blind placebo test that Gareth described. So, and I suppose that leads on into, depends who you talk to, but people talk about the 6 or 7 per million in the population might have the condition. The more we can connect, the more we can find to join people up, so that when there are trials, we can get enough people to participate. I suppose the thing that's driven me is having the condition. I'm lucky enough, I live very close to Gareth. We're not just in the same country, we're effectively in the same town, and relatively quickly got connected with the small but perfectly formed kind of MMN community in New Zealand. And as I learned about how challenging it is to get research, how challenging it is to get people interested in an ultra rare condition, really decided to try and do something about that. My natural go-to is, how do I combine doing that with doing what I love the most, probably, which is riding my bike, and hence kind of came up with things like the Making the Most of Now campaign, the Ride for MMN, And that's hopefully beneficial to others. You know, yes, we're trying to raise awareness, we're trying to raise money, but it's certainly beneficial to me. It gives me a real motivator to stay as fit and healthy as I can. And the making the most of now piece, you know, that's at the heart of it. That's about an attitude that I decided to take. And I think when whatever condition it is, but with MMN, when you realize you've got this for life, and it will, to varying degrees, disrupt the rest of your life. You know, that can take a bit of time to get used to. But I think if you know, making the most of now sums it up for me was my attitude. Because if the condition deteriorates, I don't want to have any regrets. And so that led to, how do I keep doing the things I love doing? And that's about, you know, taking care of yourself normally, eating good things. You know, it's a balanced diet. It's doing exercise you enjoy. And for me, that's riding a bike. And the great thing is I get to combine that with raising awareness. And so that's a real motivator on a cold winter's day when I don't really want to hop on the bike, but I know I've set myself a challenge which is linked to trying to raise awareness or fundraising. It can be the kick up the backside I need. And it's pretty rare for me to in fact, it never, you know, for me to go on my bike or engage with the wider MMN community and the foundation and others, it never leaves me with anything. None of those things leave me feeling worse than when I started that engagement. I might feel more tired from being on the bike, but I think it's the irony that a condition like this has given me more than it's taken away in lots of respects.
I should emphasize that when Clive talks about getting on his bike, he's not just biking down to the corner store.
Well, there could be a corner store. It's just very far away.
He's biking through incredibly demanding terrain, and perhaps I could say that one of the things that's hard, and Clive makes such a good point in the making the most of now. There is a tendency for people to say, I've got this condition that's lifelong and it causes weakness. It makes it difficult for me to do things, so I will stop doing things. And it is a battle, a greater battle for some than for others, but it is a battle to instill that attitude that I'm going to do what I can do and keep trying. And that's what I think Clive epitomizes.
Very well said, both Clive and Dr. Perry. We did get some questions as we kind of wrap up our time here together. And one of my first questions for you is talking about muscle loss. And can muscle loss be reversed in MMN?
To some degree, yes. So when the muscles become very atrophic, shrunken down, they're not going to return back to normal. They can certainly improve a little bit, and I'm sure Clive can look at his hand and still see some atrophy of the muscles there. So even though function may improve a lot, one shouldn't expect full recovery of the size of the muscle, even with effective treatment.
Also, as kind of as a follow-up in regards to atrophy, and then also some of our patients experience twitching, is that mostly limited to the limbs, or have you seen patients have it in other places as well?
Yes, very rare to have it in places other than the limbs. And I think that if someone has the muscle twitching that we call fasciculations in the torso, they should point that out to the neurologist and emphasize that this is happening, because that would be quite, I've never seen it in patients with MMN.
And then also, just a couple other quick questions. Any speculation on what causes MMN?
Yeah, important question, but one for which we have no answer. It is one of this great group of autoimmune diseases in which the body's immune system, which is designed to fight infections from without, to fight cancer and so on, it keeps us alive. It gets confused and it switches around and begins to attack a component of your body. Be it the joints in rheumatoid arthritis, or the skin in psoriasis, or the pancreas in some forms of diabetes. In this, the immune system is attacking the nerves. But why? Why does that happen? And the answer is we really have no idea at all. With some diseases we do. So in Guillain-Barré syndrome, GBS, we know that some cases are this process of molecular mimicry, whereas an invading organism has a molecular structure that is similar to the structure of nerve. And so antibodies directed against the invading organism turn around and perceive a nerve structure as being sufficiently similar that they begin attacking that. We have no evidence of that in MMN. So really, no, we don't know why this happens.
And Dr. Perry, we've gotten this message several times in the chat, but our founder, Estelle Benson, has been watching the session, and she says hello. And I know we talked about this in the practice webinar, but would you mind just, I think it's such a neat story to tell your connection to our founder and your strong connection to our foundation.
Yeah, so it's Estelle and I met around 1980 or thereabouts, and she will vividly recall, I'm sure, of eating in her kitchen in the suburbs of Philadelphia, where a group of us from the University of Pennsylvania went out to talk to her. Estelle's husband had GBS, and she became aware of a lack. There was no organization for people with GBS that would help them emotionally, help them with resources and so on. So a group of us went out to Estelle's place and met, and from that the GBS Foundation was born. And over subsequent years it has expanded to include CIDP, a chronic related disease, MMN, and some other immune-mediated diseases. So it's an interesting story.
Well, thank you. Estelle always reminds us that everything we do is always about the patient. And thank you as a young med student for recognizing that very early in your career and continuing to always, honor the patient in everything you do. So Clive, I do have a question for you, and is that it's actually about your work and if you are still actively working, which could also lead us to a tie-in about your cool background image.
Yeah, it's actually, so yes, I work. I suppose I've been very lucky since diagnosis to have had good employers who I do a 9-day fortnight, which allows me to save up effectively 3 spare days, which become my IVIG, my recovery day the day after, and then a spare day for a long weekend. So, yeah, I work. I am effectively at the moment, I'm kind of project and change manager at Antarctica, New Zealand. The backdrop behind me is some amazing wallpaper in one of our work meeting rooms, which is Mount Erebus, which is near the New Zealand base on Antarctica. So yeah, I genuinely work for a very cool organization working in a cool part of the world. But yeah, I mean, there is the reality that I was reaching the point where my typing was quite badly affected, and I've never been much more than a 2-finger typer at best. So when one of those fingers isn't working very well, that was a bit of a worry, and still remains one, I suppose. But I think technology now allows us, certainly in those kind of, when we're tied to a desk and we're typing away, those kind of jobs, there's lots of workarounds now. And I know another patient who Dr. Parry knows as well. Peter, very different world. He works as an agricultural contractor, and despite the condition, is still able to kind of drive a tractor and the many different machines that he operates. So it doesn't have to be the end of things. You might have to adapt, but I think increasingly there's lots of help out there, adaptive devices to help people, live and thrive despite the condition.
And we are just wrapping up this conversation. So I have a couple announcements, but I just wondered, Dr. Parry or Clive, if you have any last couple of words that you would like to share, some words of wisdom.
I would say just listen to Clive. Don't let this disease hold you down. It's going to cause problems, but keep going. You're not dead yet, as they said in Monty Python. And I think that keep doing whatever you can do. There's no harm will come to you by pushing yourself a little bit. And so, yeah, emulate Clive is my best advice.
That's a frightening thing to hear, but yeah, it's. Look, I'd just say, look, it's not ideal, but it's as every door closes, another one opens, and the opportunities I've had working with the foundation, getting to meet and know Gareth and others, if you want inspiration, you've got to look no further than Estelle, who founded the foundation and is still, the beating heart of it, and the patient community. And so reach out, whether it's through the foundation, people can reach me. I've had to get horribly involved in social media. And so my face is plastered over far too much social media these days. But reach out, always happy to chat to people, because, problem shared, problem halved, etc., etc. And a big pitch, my big ride for MMN is on Saturday, 300 kilometers on gravel trails in the mountains, so you can follow that. And just, I'm not suggesting everybody does something like that, because it is a bit out there, but what puts a smile on your face, is the kind of, don't be afraid to follow your dreams.
And thank you both for spending, since you guys are in New Zealand, your morning with us. We really appreciate your early risers and coming and joining us. So thank you. And if we didn't get to your question, please send it to us at info@gbs-CIDP.org, and we will work on getting your questions answered. Just a reminder that this is the end of MMN Awareness Month, but we'll be working throughout the year tirelessly to continue to bring awareness to this rare condition. I encourage you to either still time to sign up for our ride for MMN, or to do some fundraising or donate for our MMN research grant. And also, I want to thank Takeda for their special support of MMN Awareness Month. And finally, I hope you will join us again at the end of March for our next live Ask the Experts conversation. Thank you so much, Dr. Parry and Clive, and we hope to see you guys all soon.
Thanks, Maddie.
Thanks, everyone.
you.
Thanks, Maddie. Thanks, Gareth.